Hello everyone, in this video we are going to take you in a series of cases of pediatric cataract, which is a treatable leading cause of childhood blindness, accounting for 7.4 to 15.3% of childhood blindness, prevalence more in low-income countries, and about 41% of these cases are routinely diagnosed. Pediatric cataracts by themselves are complex to manage because of the factors like a growing eye, elastic anterior capsule, increased chances of post-operative inflammation, changing refractive state, and the risk of amblyopia. Approach to a pediatric cataract starts with the age and laterality of the cataract and proper history taking, including the birth and the family history, to rule out any intrauterine infections or metabolic disorders or any systemic syndromes, followed by a detailed ophthalmic evaluation. Bilateral cataract, around 50% of the cases, are idiopathic, while in unilateral cataract, traumatic is one of the most common causes, or it could be associated with other anomalies like PHPV or anterior segment dysgenesis, posterior lenticonus, or any other posterior polar tumors. Role of surgery is to clear the visual axis. We have a case of traumatic pediatric cataract, a 5-year-old male boy with a history of injury to the eye with wooden piece. Trauma is accounting for 29% of all childhood cataracts. The classical blunt trauma, it forms a stellate or rosette cataract. In penetrating trauma, if the lens capsule is disrupted, it can lead to cortical opacification. Initial patient evaluation is one of the most important critical steps in the management of traumatic cataract. The timing of surgery in children is important. The development of amblyopia necessitates prompt removal of the cataract. Usually, cataract surgery and IOL implantation can be done after 2 to 4 weeks of the primary injury repair. If synechiae is present, synechial lysis has to be performed, and it is better to avoid hydrodissection if the posterior capsule integrity is not known. Placement of the IOL in the bag improves the implant stability and minimizes uveitis, pupillary capture, and delays the PCO formation. Now we present to you a case of 8-year-old male child who had a posterior lenticonus with posterior capsular dehiscence. The patient had a visual acuity of 6/9 in the affected eye, but it needs early surgical intervention because the 8 years is the critical age for developing amblyopia. The basic objective of performing cataract surgery in this child is to clear the visual axis. Thus, posterior lenticonus in biomicroscopy is a localized conical projection of the posterior capsule and the cortex, usually present in the visual axis, and rarely it could be present eccentrically. Posterior lenticonus arises in infancy and it can progress throughout the early childhood. Development of amblyopia is the most significant visual deficit in a case of posterior lenticonus. Except for amblyopia, the final visual results after surgery were good. So, it is always necessary to undergo early surgical intervention to clear the visual axis and to prevent visual deprivation amblyopia in the child. With recent advances in the intraocular lenses, even with the presence of a posterior capsular dehiscence, foldable IOLs can be safely placed in the bag. Moving on to the next case is a 3-year-old female with anterior capsular fibrosis. In cases of anterior capsular fibrosis, creating an intact capsular rhexis may be difficult. Primary posterior capsulotomy is done as the child is less than 5 years, and anterior vitrectomy is done, followed by in-the-bag intraocular lens placement. Vitrorhexis is a good alternative to manual capsular rhexis in case of fibrotic capsule. Very dense capsules can also be removed with intraocular microscissors, radiofrequency diathermy, or a phugoplasma blade. We move on to a 4-year-old male child with surgically induced aphakia undergoing secondary IOL implantation. Once the incisions are recreated, vitrectomy is done and the chamber is filled with viscoelastics. When performing infantile cataract surgery without primary intraocular lens implantation, leave an adequate capsular rim for subsequent IOL implantation. A 4.5 mm central, posterior and anterior capsulotomy is usually adequate to prevent opacification of the visual axis, but assures an adequate rim of support when secondary IOL implantation is elected. While corneal tunnel incisions are usually utilized for secondary IOL implantation, a scleral tunnel incision should be considered when the capsular support is limited. Assess whether it is possible to reopen the capsular bag leaflets. The key is to locate one area in which the anterior capsule edge is not strongly adherent to the posterior capsule. In the absence of available capsular support, sutured IOLs, iris glo lenses, or AC IOLs can be used. So, to conclude, pediatric cataracts are challenging, but with proper history taking and evaluation, good surgical techniques, and taking proper postoperative care and rehabilitation, taking care of the growing refractive error, we can achieve an optimal visual outcome in the budding, growing eyes. Thank you.